Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, MRCOG Part 1 candidates. How are you? Okay, today, inshallah, we're going to have, inshallah, a powerful revision over the most important recalls. I'm going to start with the latest one, January 2025, and then go back, okay, retrospectively. So I wish we are going to finish all the questions in this file because there is another one. So hopefully, let's see. If you are quick, we are going to finish as much as we can. I didn't insert the questions for year 2025 at the beginning, at least the new ones, so that you are not shocked. And I don't want you to feel depressed or anything. And let me remind you guys, any new information that we gain before the exam is better than getting it after the exam. Okay? And let's say Bismillah and start. And I'm going to tell you some hints and tricks while we are answering the questions. So please, if you have notes or anything, try to write it down with me. This kind of questions are now very trendy in the RCOG. They are bringing you the options in the form of a box or a table like this, and they're going to ask you to choose the best answer from them. So, for example, here, the upper part of the vagina receives a blood supply from which arches? So, option A means aorta, external iliac, uterine. Option B, external iliac, internal iliac. Option C, uterine and ovarian, and so on. So, what do you think? Okay, got some answers. Yes, exactly. The uterine, and there is no vaginal artery in the options. Yeah, I know it's vaginal, but if it's vaginal is not here. Of course, it's uterine and ovarian artery. Okay, or more precisely, it would be the uterine and vaginal. Yeah, I know. I'm not sure. I'm not really sure that this is the true options, but you are right. Definitely, it's the uterine and vaginal artery. Definitely. If it's not here, so yeah, anastomosis. No, direct branches. Okay, this is very good example of what I was telling you. One of the tricks in your exam that one of the options could be right, but it's not the direct branch. Like for example, guys, for example, when they ask you about the blood supply of the descending colon, okay, would it be the inferior mesenteric or something direct branch to the descending colon? Always choose the direct branch. You got what I mean? Shall I repeat again? Because this is also a recall, by the way. Okay, the descending colon is supplied by left colic artery or the sigmoidal arteries. It takes branches from the sigmoid artery also. Both of them are branches of inferior mesenteric. If both of them were there in the options, go for the direct one, the left colic artery, not the inferior mesenteric. Okay, Dr. Yakaka, you got me. Okay, here this patient is having 6 years of infertility. and she's now pregnant at 7 weeks. She came with spotting. The ultrasound shows positive fetal heart rate, 2 hyperechoic lesions. I guess they were well demarcated. If I remember well, I think we can add this. They were well demarcated also. I don't know if they were 1 or 2. I'm not really sure, but they were about 3 centimeters. No mass in the adnexa. What do you think this diagnosis is? Forget about what I highlighted or whatever, okay? I could do some typos. So you tell me, what do you think? Do you agree that this is a pregnancy with coexistent fibroid, or do you think that it could be any other thing? Okay, let me do some exclusions. Yeah, let's do it. Number 1, the presence of a positive fetal heart rate does not mean that this woman is having inevitable miscarriage. No way. I'm having a live baby, okay? And they didn't tell me anything about the cervix. You tell me, guys, if the cervix is open or closed, this is going to be inevitable abortion. Open, excellent. So I need open cervix with bleeding, okay, and a positive fetal mass or positive heart rate in a fetal mass. Now this is, yes, inevitable abortion. Okay, here I don't have this. I just have someone with spotting and there is hyperechoic lesions. I asked my candidates, and they remember very well, I asked them, was those lesions are in the uterus or in the ovaries? They said no, in the uterus. I said, okay, so no mass in the adnexa? They said yes. So that means that the ovary and the tubes are free. This is not ectopic. Okay, could be this a twin gestation? No, a twin gestation means I'm going to see at least 2 sacs or 2 fetal masses. Even if one of them is not showing fetal heart pulsation, I don't care, but they are 2 sacs or 2 fetal masses. So here, this is mainly 2 polyps. The hyperechoic, well-demarcated lesions are usually polyps. They said uterine fibroids, it's okay. I don't really like the specification in the scenario. They should be hypoechoic, not hyper. Okay, because fibroids are not hyper, they are hypoechoic, while polyps are hyperechoic. Anyway, they were not very specific. It's okay. By exclusion, this is not occasional finding. This is not inevitable abortion. This is not ectopic and definitely not a twin. This is January 2025, by the way. I think we have started their questions. What is the maximum achievable increase in hemoglobin level using oral iron supplementation? Even if you don't know this, okay? If it's a new piece of information for you. Let's revise together. What should we know about anemia in pregnancy? Okay, and what is oral iron trial? What is this? Anemia in pregnancy, guys, is diagnosed when the pregnant lady is having hemoglobin less than the cutoff for pregnancy, not like any other adult. For the first trimester, what would be the cutoff of hemoglobin to diagnose anemia? Less than what? 11. Excellent. In the second and third trimester, 10.5. Postpartumly, less than 10. Excellent, guys. Okay, what would be your first or initial investigation for diagnosing iron deficiency anemia? I'm going to tell you this. The diagnostic investigation would be a trial of oral iron. If you gave this woman, because mostly microcytic hypochromic anemia in pregnant patients are because of iron deficiency. So we are going to give them oral iron, oral elemental iron. It's what we need, because this could be exam question also. What we need to give her is about 35 milligram of elemental iron. Okay, okay. So I'm going to give her at least 35, and in 2 weeks, 2 to 3 weeks, or 2 to 4 weeks, I'm seeing that her hemoglobin is coming up. This is like definitive diagnosis of iron deficiency anemia. In case you are still not really sure what type of anemia you are dealing with, or you are suspecting hemoglobinopathy, you can do the oral iron trial at the same time of doing tests for hemoglobinopathies. The second step would be the ferrous level, or the ferritin. Ferritin. So we don't really do ferritin initially. We don't do this. Okay, what is the acceptable level of ferritin? Or what would be the level diagnostic for anemia? Less than 30. Less than 30. Okay, this question is truly a silly one, because we are expecting to see the increase in hemoglobin by 2 grams in 1 month. Okay, maybe other resources are going to tell you, we are hoping for more. I'm telling you here the reasonable increase. Reasonable increase means I'm going to expect the hemoglobin to increase by 2 grams per deciliter within 3 to 4 weeks. Okay, this is according to our college. Increase of 1 gram per deciliter within 4 weeks is very reasonable. If we divided this per week, we are going to have 0.4 to 0.5 milligrams. Okay, again, 1 gram increase by day 14 is a predictor of sustained response to oral iron therapy. So this woman is going to have an excellent response to oral iron. Okay, so this is by far everything that you need to know about iron. Of course, if you have in the exam a CPC picture, and this CPC picture showed macrocytic hypochromic anemia, are you going to suspect that this is iron deficiency anemia, or which mineral deficiency, or which vitamin deficiency? Macrocytic hypochromic. Macro. The RBCs are big. Yes, vitamin B12 and folic acid, both of them together. This is megaloblastic anemia. Yes, megaloblastic anemia. So we are going to give vitamin B12 and folic acid, both of them. Okay, excellent. This is a staging question, and it's not the first time that you have a staging questions. I remember in my exam, which is very old, I had a staging question, which was 2B, no, 2A. I remember it very well because I answered incorrectly. Okay, they were asking about the involvement of the upper vagina. Okay, so this is 2A, and it's also very famous in the exam. Here, they were more mean. Honestly, they were more mean. They asked you about very specific features, okay, which really necessitate that you remember the staging very well. They answered you about cervical cancer. Sorry, asked you about cervical cancer extending 9 millimeters in width, and 6 millimeter in depth. So let me tell you quickly general rules about cervical cancer. We care about the depth, of course, more than the width. This is one. Number two, we care about the presence or absence of lymph node involvement. This is very important in management. And the cut-offs for a stage and the other one, 3. So we start with 3, okay? 3 millimeter in depth and 7 in width. So anything less than 3, this is CIN. Okay, less than 3 millimeter, this is CIN. Because it's very, very little. And I don't think that if they like giving you a scenario about invasive carcinoma, which is only 1 millimeter or 2 millimeter, okay, yeah, I can do stage 1. This is only stage 1. Which subtype? We don't have a subtype for this because it's very little. From 3 to 5, I am in A, stage 1A, 3 to 5 in depth. When I'm more than 5 in depth, but less than 4 centimeters, this is 1B1. More than 4, 1B2. So they brought you a very tricky one. I'll be honest. Why? Because they are looking for a microscopic invasion. This is microscopic invasion. This is not clinically visible, but still bigger than 1A2. Okay, so this is like something between this and this. And by the way, this classification is new. It wasn't there before 2022, 2023, which is the latest figure. Okay, so here we are. Again, when you are having something less than 4 centimeters, okay, but at the same time, it is more than 5 millimeters. Now I'm B. I'm stage B. More specifically, B1. Still, we are having the same, okay? This previously was 5, not 4. It's now 4. But the same stage 2, the same stage 3, and so on. So stage 2, again, when you are having extension beyond the cervix, and it's an old recall, which involves the upper 2/3 of the vagina. This is 2A. Involve the lower third of the vagina, 3A. Okay? So as you can see, depth is going to lead you to a greater stage, not the width. Not the width. So the depth is more important. Okay, and it's more important in management also, how far we are going to inoculate this tumor. Okay, this one is a really good one also. This pregnant, 16 weeks, she's HIV positive, and this is a very important piece of information because without it, I would have a total different diagnosis. She's having microscopic hematuria. Okay, this is evidence of bleeding. The platelets are 9 million. The AST and ALT are slightly raised. The PT and PTT are, of course, somehow prolonged. The hemoglobin, anemia. So I'm having anemia. And I'm having MCV. I don't think it's abnormal. They are going to bring you the normal values, guys. Don't worry, okay? So I'm having anemia, but it's not microcytic. And I'm having polychromasia or polychromatosis. This is something not promising at all. Polychromasia means immature RBCs. This is something very unpromising. And myeloblastosis. Oh my God, this is also immature white blood cells. White blood cells, and even if they said it can also, we can include the platelets, immature platelets in it. So this is something very bad. Okay, I'm not talking here about anemia. It's not only anemia. There is occasional RBC fragments. Okay, so what would be your diagnosis? You know, without HIV positive, I would diagnose this as myeloma. Definitely. This is myeloid leukemia. Okay, a typical case of myeloid leukemia. But here they mention that this patient is HIV positive. So yeah, maybe this is because of the HIV. It happened. Okay, it's not familiar, okay? But this could happen with people who are having uncontrolled or high viral load of HIV and very low count of CD4. Okay, so yeah, we can have polychromasia and we can have thrombocytopenia and myeloplastosis because all the bloodlines are depressed. All of them are depressed. This also can happen in radioactive patients. Any patient who take radiotherapy, they can have bone marrow depression, right? Or viral infection. Viral infection in someone who is having low immunity. And the viral infection now is attacking the bone marrow. This also can happen. Without this, and this, and I'm only having a patient with bleeding, of course, not HIV, not necessarily HIV. She's having microscopic hematuria, which is evidence of bleeding, with thrombocytopenia, okay? Plus or minus anemia. This, of course, could be ITP. And ITP, I don't need the anemia. I just need history of bleeding or bruises, okay? Or very prone liability to get bleeding or bruises, okay? And thrombocytopenia. This is ITP. Okay, if it was, let's say, gestational thrombocytopenia, what would be her history? If you doubt and you think that, of course, without I have omitted, okay, I omitted the polychromasia and myeloplastosis. I omitted them with only this scenario here. Okay, how would you know that this is ITP, not gestational thrombocytopenia? From the history. From the patient history. The patient in gestational thrombocytopenia, she's going to tell you, I have never had episodes of bleeding or easily bruising. This is my first time. And sometimes she is totally asymptomatic. And we discover the thrombocytopenia incidentally. Okay, so gestational thrombocytopenia usually is discovered incidentally through the routine CBC, but there are no symptoms. ITP is someone who is having evidence of bleeding, which is here the microscopic hematuria. And she's having history of having frequent bleeding from her nose, from her gums, easily bruising, or even easily bleeding from any cut wound. Okay, TTP is totally different. In TTP cases, we are having a case who, yes, she is also having thrombocytopenia, but she is having what else, do you know? CNS manifestations. She's also having CNS manifestation. Okay, so it's nothing to do with this one. preeclampsia. Where is the blood pressure? Would I say that this is blood? Where? How I would diagnose preeclampsia without high blood pressure? Is it HELP? HELP is hemolysis. Okay, I have hemolysis. And elevated liver enzymes. Okay, I have elevated liver enzymes. And low platelets. Okay, I have also low platelets. But what those are doing here? We don't have myeloblastosis or polychromatosis in HELP. Why the other bloodlines in the bone marrow are depressed? So think about it in the exam, guys, logically, even if I don't know the information needed for the question, I can do exclusion by logic. Okay, and if you are stressed during the exam, just flag the question and get back to it after you finish all the questions. Okay, the next one is a very common recall. And no matter what, it's very common. I keep seeing incorrect answers through the groups, and I don't really know why. What's wrong with you that makes you answer choroid plexus being in between the biomatter and arachnoid, between arachnoid and dura mater? Like, really? Choroid plexus is in the brain itself. The plexus inside the brain tissue itself. And it resides there and it vaginates the ventricles. We need the choroid plexus so that the nutrients and minerals in the blood are going to be exchanged with the CSF in the ventricles. This is what the choroid plexus do. So if they ask you, where is the choroid plexus? And you need to answer. I would choose ventricles. I would choose the brain tissue. I would choose choroid fissure. I would choose, which is not very specific, something between the brain itself and the biomatter. Okay. I would say fine. But anything above this level is totally wrong. Totally wrong. Okay, so please, I beg you, the choroid plexus here is meant to exchange the minerals and the nutrients between blood and CSF. So I have to become in contact with the CSF. The CSF are the ventricles. Those are the ventricles of the brain. Okay? And the invagination in which the choroid plexus reside is called choroid fissure. Inside the brain tissue itself. Okay, guys? Specifically speaking, which ventricles we are talking about? The lateral, third, and fourth. Okay? Hopefully. Okay. This one also was a new question, but not totally new. The new thing is, they now mention the titr of the RPR test. This is a scenario of syphilis serology, and syphilis serology is very famous in the exam, just like the hepatitis. Okay? And they were telling you that the RPR titr was 1 to 2. Now, and she had a treatment 12 months ago. The titr before the treatment was 1 to 128. Okay, this is improvement. Even if I don't know anything about the cutoffs of the titr, even I don't know anything about the RPR titrs, something was 1 to 128. And now it's 1 to 2. Okay? What do you think? Is it getting lower or higher? Forget about what I have done here. Forget about it. Let us have a quick look over it. Which one is higher, 1 to 2 or 1 over 1 to 8? And they also told you that 6 months ago, the treponema EIA and TPPA both positive at cooking 6 months and 12 months ago. So I'm having the EAA and TPPA both positive. One over 1 to 8 is higher or 1 in 2? Okay, so Dr. Medina, yes, you are right. 1 to 128 is higher. Yes. Okay. Yes. Excellent. Because the RPR titr, guys, it goes this way. When we are having a titr, for example, 1 to 2, and then we are having a titr 1 to 4, and then 1 to 8, that means that we are getting higher and higher load of the syphilis. Okay, so yeah, this woman before the treatment, she was 1 to 128. Now it is 1 to 2. So she's getting lower. The titr is getting lower. Okay, fine. And still, the EIA and TPPA positive. I need my candidates, please, to tell me if both of them are positive. Does that mean that the woman is having syphilis, or this is a false positive test? I'm not asking you now about the type of syphilis or the stage. No, I'm just asking you, is that a positive syphilitic case, or this is a false positive? When you have both treponemal and non-treponemal tests positive. Anyone? You know that this could be simply your exam question? Forget about the titr now. If EIA and TPPA both are positive, now, this case is a true syphilis case or a false positive case? True one, definitely a true one. Yes, I'm having both treponemal and non-treponemal tests positive. So yes, this is a true positive syphilitic case. Now the question is that active one, a primary one, or a secondary one, or a tertiary one, or a latent one? When we say active syphilis, that means primary, secondary, or sometimes tertiary. When we say latent syphilis, latent is early latent and late latent. Forget about all this. I know for sure that this woman is having syphilis. Okay. Now the question is it treated or untreated? And is it active or not? You can see my screen? I think Okay? Yeah, sure, dear, inshallah. When we are done. So I think from my very humble point of view that this is a treated one because the titer is getting down, right? So surely this is a treated one. I cannot say that this is a late untreated syphilis. I cannot say that this is active syphilis because how come active syphilis? Why she got a treatment 12 months ago? From the history, guys. So even if I don't know what are tips, this is something new to me. I'm really astonished and shocked by the exam questions. Use your mind. Use your mind, guys. If you know how to interpret the syphilis serology, that's it. I just want you to know that when both of treponemal and non-treponemal tests are positive, this is a true positive case. No way that this is a false positive case. Another very famous exam recalls, and I know why they change it, because most of the candidates now are aware of it. When I'm going to change a little bit about this question, okay? So let's see here. Let's say that the EIA came out to be positive. The TPPA is negative. The patient came in booking, okay? Let's forget about all of this. Okay. What would be your diagnosis? And let me tell you, active syphilis, late syphilis, false positive serology, this is very famous question. False negative serology. Treated syphilis. Yeah. Let's say treated syphilis. Had syphilis, treated. Choose one of them. Excellent, Dr. Faisal. Excellent. Now I'm having one of the tests positive and the other is negative. So I'm not really sure if this is a real case of syphilis or not. By the way, in this case, I'm going to repeat the test again, okay? If the patient is high risk. Why? Because there is a possibility that she is not yet to appear in the treponemal test, but forget about it. Which kind of test you should rely on to say that this woman is truly having syphilis? The treponemal or non-treponemal? Treponemal, yes. Yes, treponemal tests. TPPA, TPIA, any immunofluorescence, okay? But not EIA, not RPR. Okay, RPR or EIA are not specific. So I'm not going to depend on them to say that this woman is really having active syphilis. This can happen during pregnancy, and this is a very common case in which we call false positive serology. False positive because this positivity is false. This positivity happens because of the dilution in the patient blood during pregnancy. Okay, I can give you another scenario, by the way. We can vice versa. We can put the IA negative and the TPPA positive. What could that be? This is usually secondary or latent syphilis, yes. Because sometimes the non-treponemal tests are going to render negative after some time. So after like a year or a year and a half, that the non-treponemal tests are going to render negative. But once treponemal tests are positive, they are always positive, always positive. They are not going to become negative. They are always going to be positive. Okay, so one of the famous cases that you may meet in your practical life, seeing the EIA or the RPR negative while the TPPA positive. This is not an active case. Okay, this is usually very late secondary syphilis or a latent syphilis. Okay, excellent. Okay, another very famous question that, again, it makes me furious to see wrong answers among the groups. What is the narrowest part of the fallopian tube? Very common recall, guys. This would be the intramural part or interstitial part of the fallopian tube. This one here, this one. And this is where we insert what's called insure. It's not licensed in the UK now. Okay, it was one of the ways of contraception where we are blocking the fallopian tube. Okay, it's like you can say it's a matter of I forgot the word. What do we call it when we permanently reduce any chances of contraception? Sterilization, yes. Yeah, I got it at the same moment. Thank you, Dr. Yusha. Sterilization, yes. So this method is now obsolete in the UK anyhow. And the issue was a coil. Okay, and this coil was inserted in the narrowest part of the fallopian tube, which is intramural or interstitial. Both are the same terms. Not the isthmus. Okay, not the isthmus. And I really don't care anyone would answer it incorrectly, but those who are attending with me now, I'm begging you, it's not the isthmus. Allahumma ballaght. Okay, where would you insert the needle of epidural anesthesia? Another question with a different formula. They were asking you about anesthesiologist who was trying to insert epidural catheter, and while he was inserting the epidural catheter, CSF comes out. So where did the anesthesiologist insert the catheter? So those are two forms of the question. Let me tell you the difference. In epidural catheter, guys, we should go in the epidural space. And the epidural space is not where the CSF is. So I shouldn't see CSF coming out, which is, by the way, needs a hell of experience and a very good hand. So the anesthesiologist is going to insert the needle here. Okay, and just feel one click, the click of the ligamentum flavum between the vertebrae. That's it. It's not going to move in any further. Just the click of the ligamentum flavum here. The ligament that connect the vertebrae together. Okay, one of the ligaments, of course. So once he punctured the ligamentum flavum, he's going to insert the catheter here and enter the analgesia, which is by far, if this is going to be your exam question, the most common material or opioid that we use for in epidural analgesia. Do you know which one? Remifentanil. No, this is for the skin. This is a local anesthesia for the skin. The main one. Yeah, we can use bupivacaine. This is what you use in your practice, I think. Remifentanil is safer. Remifentanil. Okay, and this is according to the NICE guideline, not me. Remifentanil now is the best. Okay, so this is the epidural. This is totally different of the spinal anesthesia. When I'm going here with the epidural catheter, I'm between what? I'm between the ligament or the bony vertebra and the dura mater, the hardest dura, the hardest one, the hard muscle, mother. They call it like this, hard muscle, mother, sorry. Okay? While pia mater is the passionate mother. P for soft, passionate. D for hard, dura. Hard dura. Okay, so in spinal anesthesia, for example, I think I got another picture. Where it went? Ah, here it is. Okay. Here we are in the spinal anesthesia. I'm going to puncture the ligamentum flavum and the dura mater. So I'm going to hear 2 clicks, not only one, or feel 2 clicks or 2 resistances. So that I'm going to reach spinal space. What is the spinal space? Arachnoid space. What is the arachnoid space? Which is normally called subarachnoid space. So I'm now between the arachnoid and the dura mater. Okay? This is where I am now. I'm between what? I'm between the arachnoid mater and the dura mater. This is the spinal space or subarachnoid space, which is totally different from the epidural anesthesia. If you have any problem, stop me. Okay. Again, another exam question which I like so much. I like it because it differentiates between someone who really understands the dermatomes or the distribution of anesthesia or pain through dermatomes, and where we are going to inject our epidural to achieve a nerve block. Both are different. How? When we give the epidural or spinal anesthesia, our aim is to block the nerves at a specific level, right? So if you know where the contractions are going to start, usually we are going higher than this level. And if you block here, for example, okay, if you block here at the level of T4, that means that everything beneath T4 is sleeping now, right? It is sedated, blocked. So all the nerve roots downward are blocked. This is very high level and usually for emergency theater. okay? Not for all cases, but usually when we need to do a spinal anesthesia, whether it was by epidural or spinal, okay, which is, we call it regional anesthesia. The general term for spinal and epidural is regional anesthesia. Regional anesthesia is going to be inserting the epidural or the spinal needle between T8 and T10. This is how I'm going to have numbness at all the underneath levels, which makes sense. You know why? Because the contractions are referred to T10 to L1. So if I start from T8, that's perfect, right? In early stages of labor, the pain, okay, related to the dermatomes T11 and T12, okay, are going to appear. So I'm starting getting the pain in T11 and T12. Then they are going to spread up and down. So let's say we are having the T12 and T11, 11, 12. This is how the first stage start with, and then it's going to spread up to T10. My mouse is killing me. And down low, down to L1. By the second stage during labor, while the head is coming down, the pain also is going to involve S2 to S4. So this is why when I block from T8, that's amazing. If I block at T9, well done. So I'm having like a region from T8 to T10. This is where we should insert the epidural catheter or the spinal anesthesia. And by the way, I think, if I'm not wrong, that this appeared in the exam before. The pain is going to be referred to which dermatome during the second stage. And very old recall was which labor pain, which dermatome is going to receive the labor pain during labor in general. And it's a strategy question, by the way. This is T10 to L1. T10 to L1. This is contractions pain. The pain here in the second stage is not contractions. They are because of the dilatation and the passage of the fetal head in the vagina. Okay, so contraction pain is from T10 to L1. Are we good so far? Are we good so far, guys? So you reminded me to send you a very good, whatever you want to call it, a flashcard or a small infographic about analgesia in labor. Okay, just in case they asked you about why remifentanil is better than any other thing, in particular pethidine. Why remifentanil is better than pethidine? Okay, just like when they asked you before why the misoprostol is better than other prostaglandin. Do you remember this question or not? This question source was SIP, Scientific Impact Paper. And it just popped up in my mind now. So let me tell it to you. There were a comparison between misoprostol, okay, and dinoprostol. And let's say from the early beginning, we always favor the dinoprostol over misoprostol in induction, right? But in the scientific impact paper, they were focusing on the usage of low-dose misoprostol. So if we use the low dose misoprostol, not the usual dose, a low dose misoprostol, we can achieve good induction, and at the same time, it's going to result in less risk for CS. This was like a totally new piece of information that was mentioned in this SIP 2 years ago, and it appeared in the exam. Okay, so I think why not? They are going to tell you about remifentanil. I can put it to you here even because it's related. They can ask you about how remifentanil is better than pethidine, for example, as a pharmacology question. Okay, and they can ask you about which pain management could be offered to patients, which one is safe, which one is unsafe, or whatsoever. Okay, so they are telling you, for example, one of the things that can be used and it's really effective for back pain, intracutaneous or subcutaneous sterile water injections. Okay, this is now valid, okay, and licensed. You can use the intracutaneous or subcutaneous sterile water injection for back pain. This could happen for you, by the way. This could be a part 1 exam question. Okay, another exam question here. Which, for example, type of analgesia is used for PCA? Remifentanil. Again. Okay, guys? Are you following? Okay, if I zoom in, because I really don't, I cannot read this one. Okay, so I'm going to zoom in like this. Okay, some counseling points about epidural. This is something for a part 1 candidate. Okay, he should know, for example, that epidural are not associated with long-term backache. Epidurals are not associated with longer first stage of labor or increased chance of unplanned CS. Epidural are associated with longer second stage, increased chance of birth with instrumental delivery. And this is why we are going to give a longer time in second stage for those who are using epidural. For example, if I'm going to give a woman a chance to stay in the second stage for 3 hours, they are going to be 4 hours if she's using epidural. For multi, if they are supposed to only have 1 hour in the second stage, I can go for 2 hours because she's using epidural. Okay, so because we use remifentanil, for example, for epidurals, okay, or if they use the PCA with remifentanil, this is better than the pethidine, which is very quick and very efficient, but it's contraindicated in many cases. So we really become afraid of pethidine now. So if you use the epidural with remifentanil or PCA with remifentanil, it's likely to need an epidural or instrumental delivery if you use PCA with remifentanil with the patient, which is really good. Spontaneous vaginal birth is more with remifentanil PCA, but you may need supplemental oxygen. I just want you to remember this so that if it appears by any means in your exam, definitely you should know which type of pain management during labor is not advised or not recommended. Okay. We have this case with Meg's syndrome. And when they say Meg's syndrome, that means what? What is Meg's syndrome? Forget about they have mentioned the specific type of cells and so on, but what is Meg's syndrome? It's a syndrome that it's going to happen because of the metastasis of ovarian cancer, right? So if the choices were between ovarian cancer, liver cancer, pulmonary cancer, and so on, so it's now very easy. This is ovarian cancer. What type? I don't think they mentioned a specific type of ovarian cancer, but anyway, exactly, pleural effusion, ascites, and the evidence of ovarian cancer. So here, they mentioned that the pulmonary biopsy revealed spindle-shaped cells. Okay, spindle-shaped cells is one of the cells that are very famous in pathology, which means usually this is ovarian fibroma. And this is what I need to know. That's it. But definitely it's an ovarian cancer. Okay, and here it is. We have the clue. we have the evidence of having ovarian cancer, a spindle-shaped cell. Okay, and they told me that this is the Meg syndrome. By the way, previously they used to ask you about what is Meg syndrome. Again, now they are upgrading the questions because they know that most of the candidates now are aware of the question. So guys, please, I'm begging you, in those very few days, if you are going to use the recalls, don't use it copy-paste in your mind. Use it as a method to know a topic or a piece of information. Okay, try your best. Like for example, this one. If I'm having a question related to cells, I should have a quick review over some featured cells and their association with specific type of ovarian tumors, because this appeared before. They used to ask about Scheller-Duval. They used to ask about Samoma body, and this is a strategy question because they are very famous. So if you see a coffee bean nuclei or Cole Exner, very famous for granulosa cell tumors. Samoma bodies, serous epithelial tumor. Even they can bring you a picture. I forgot to put this picture. This picture also was exam question. A cut section like this, and it was full of laminated pink material like this. This is Samoma body. Very famous, okay? Signet ring cell. Krughenberg tumor. So yeah, they are old questions, but why not they can appear again? Why not? A teratoma. If they told you that during the ultrasound we have found out cartilage, teeth, skin, okay, or the pathology revealed this is a teratoma. I think you got what I mean. Okay. This is a statistical question in the January 2025 exam. So let's see. They were testing preeclampsia or something, or a test for a preeclampsia. The test results showed a likelihood ratio 12. I think this is positive likelihood ratio. Let me correct it. The positive. If any of you have attended this exam, you can help me out with a better scenario. The positive likelihood ratio is 12. while the negative likelihood ratio is 0.02. How useful the results are. Simply, if you don't know how to interpret likelihood ratio, forget about the question, say bye-bye, and skip to the other one. Okay, you still have a chance 1 in 4 to get the right answer. So try your chances, try your luck. Otherwise, if you know, then congratulations, this question is very, very easy. Remember my words, guys. Any ratio in statistics, when it is approaching 1 or equal 1, it is having very low significance. A ratio equal 1 means that there is no difference between the input and output. There is no difference between the variables and outcome. Simply, we are doing all the tests and studies to answer a specific question. Is what I'm doing now valuable or not? Is that investigation is going to show me something or not? Is that drug is going to be curable or not? So if I'm trying a test or investigation, for example, and the likelihood ratio before using, let's say, ultrasound in preeclampsia, which is, by the way, a very good topic to start with if you are doing your researches. If you are using the ultrasound as a marker for preeclampsia, okay, so you have done the Doppler for a specific thing, let's say umbilical, no, uterine artery in the very beginning of pregnancy, okay, and you had some values, and you are trying to predict, according to those values, whether this woman is going really to have preeclampsia or not. Okay, okay. So likelihood before using preeclampsia was 30. Okay, after using the ultrasound, it's 30. Now get me a ratio, please. Before and after. 30 over 30, 1. That means nothing. This is insignificant. That means that the ultrasound or my study is insignificant. It does not mean anything. It didn't lead me anywhere. Not in the positive direction or in the negative direction. So this is why, if you are having anything above 1, okay, I'm going up now in the positive likelihood. And the more and more I'm getting up, the more significant my results are. For the negative likelihood ratio, vice versa. The more, the little, the more the significant. So less than 0.1 is good. More than this and approaching 1 is bad. So simply any ratio in statistics, when it's 1, it's really, really bad or insignificant. When I go far from 1, whether it was positive or negative, this is good. Whether it was likelihood ratio, risk ratio, give me some ratios in your exam. We have the likelihood ratio and risk ratio. What else? Odds ratio. Yes, excellent. Odds ratio. All of them, when they are 1, they are insignificant. When they are less than 1 or more than 1, this is significant. If I'm here, this is minimal change. Here, okay. Here, moderate. Here, significant. And same to same with this direction. Got it, guys? So, as you can see, I'm having both of them useful. Both of them. Another Very important point. Oh, can I have some ratio of them useful and the other one is not useful? Yes, you can. Yes, you can. It's possible that you get a good positive likelihood ratio and a bad negative likelihood ratio. That's normal. Just like you are getting a good sensitivity of a test and a bad specificity of the same test. It's simply, this means that this test here can rule out a condition, rule in, sorry, because it's positive likelihood, rule in a condition, but it cannot rule out the condition. Okay? So yeah, this can happen, yes. So if in the exam, they got me a negative likelihood ratio of 1, or let's say 0.8, 0.9, this is very close to 1. This is bad negative likelihood ratio. Okay, the frequency of balanced translocation in Down syndrome. Do you remember the numbers in Down syndrome? Do you remember how many Down syndrome are going to happen because of non-disjunction? What is the most common mechanism of Down syndrome? Non-disjunction. Excellent. Do you remember the percentage of non-disjunction in cases of Down syndrome? Almost, this is by far the most common one. About 94 or 96, if I remember well, up to 96, yes. In some literatures, 98 also. Okay, so if we get the average, about 94%. Yeah, 94, 95. Okay, so the amount of dislocation or the incidence of sorry, not why I'm thinking about dislocation here. Balanced translocation. No one? It's about 4%. And I'm not really sure of the number that appeared in the exam because none of them were correct. So I don't really know what appeared in the exam, but I think it appeared like 1 in 20, 1 in 40, 1 in 400, and so on. Robertsonian is one of the type, yes. I'm trying to get you a table that is going to help you a lot. I really wish it's here. Once upon a time, they were asking about the chances for someone who is 35 to have a baby with Down syndrome. We call this age-related risk. Okay, sometimes they asked about the recurrence risk, but this is a very old question. The recurrence risk, if a lady was having a special type of translocation, I just need you to know that if the translocation was in the gene 20 or the chromosome, sorry, 21, So I'm having now translocation between 21, 21. That means that all of their offsprings are going to be down. All of them. Why? Because the translocated chromosome is the chromosome number 21. So I'm having the two chromosomes of 21 in one chromosome. So definitely, if the father is having this, and this is balanced, why balanced? Because he is having the same amount of genetic material. And of course, those people are going to have only 45 chromosomes. The 46th one is attached here. It's here. So this male, for example, when he is going to inherit this type or tall chromosome, which contain 21, 21, and the baby is going to get the other 21 chromosome from the mother. Now count, how many 21 chromosomes do we have? 1, 2, 3. Down, baby. Okay? So this is why when the translocation is 21, 21, definitely all of their kids are going to be down. When the translocation is in the other famous sites like chromosome 13, 14, 15, the most famous one, 14, okay, they are going to have recurrence risk between 3 to 15, according to whether the mother or the father are which one of those are having the balanced translocation. So I'm going to get you the other one. I hope it's here. I hope the number you know, guys, that this also was exam question, and I think it was a picture. Yeah, it was a picture. I remember this one. It's one of the recalls. I'm not sure it's a recent one. Recent means in the last 2 years. So this, for example, this picture appeared before in the exam. So anything else can appear, right? Any type of chromosomal mutation can simply appear as a picture, whether it was translocation or addition, okay, or deletion. So yeah, they brought this exact picture here and asked you about the type of chromosomal abnormality. Also talking about, you know, that there are questions regarding cell division. There are very famous, which cell stop or cell checkpoint is meant to be for DNA fixation, which cell cell cycle checkpoint is meant to be for cellular mutation. By the way, they are different. Okay, for the DNA mutation is different from the cell structure mutation or any other type of mutation. Do you know which stage in the cell cycle is meant to be for checking out the DNA mutation? Which stage in the cell cycle? For DNA? We cannot find it here. Anyone? Give a hint. No, of course it's not mitosis. I need it before mitosis. I need to fix any DNA damage and discard any DNA abnormalities before mitosis. I used to tell the small kids, okay, that those points are meant, subhanallah, to give us the best DNA material and the best chromosome. So all of this are going to be done before mitosis. All of the checkpoints, the needed checkpoints, are going to be inside the interphase, not the mitosis. And the interphase is the one that contains G1, S, and G2. Then, before mitosis, in the M phase, we are going to have the last checkpoint. The one that take care of the DNA is S phase. Let me put it here for you. Please, guys, if you encounter any black box, please tell me, because it's usually because of the chat box. So if any black box appeared in the screen, please tell me. I have done it all in one page. Okay, I think we're good so far. Okay, this one is also a new question, which I hate from the bottom of my heart, because actually this is very not basic knowledge. Okay, this is not a basic knowledge. You can get it by exclusion if you know much about tumor suppressor genes, but no one in part one know this. So anyway, those kind of questions are meant to be. They love to bring any new question, 1 or 2 questions, up to 3 questions, totally new, no one have ever heard about, and in many situations they are not going to be repeated. Okay, so anyway, the tumor suppressor genes, guys, are the famous that we all know, that when they are mutated, you are going to get cancer, God forbidden. So if you are having a mutation in BRCA1 or BRCA2 or P53, you are going to get a cancer. Okay, when those are mutated, we are going to have a problem because they are tumor suppressor genes. This is also happening to the PCI2 or the RB, retinoblastoma, I think. Okay, so I guess if you want to remember something, BRCA1 and BRCA2, of course, because they are the very famous in our practice. And I need you to remember also the incidence or the risk, sorry, not incidence, the risk for ovarian cancer and breast cancer in cases of BRCA1 and BRCA2. Those were very famous exam questions. And B53 is really, really, really important in endometrial cancer and also in ovarian cancer somehow, but now it's having a huge importance in vulvar cancer. Vulvar and, vulvar one, especially the one that is not associated with HPV. So this is why there is a big spot on P53 now and PCR. So here the answer is going to be this one. And if you got this incorrectly in the exam, no one is going to blame you. Totally forget about it. Okay, I need to get this up. Okay. Here we are. Which nerve primarily supply the perianal area? Again, we are dealing with a direct branch and indirect branch or indirect supply. I don't want the major supply. I want the direct branch. Inferior rectal. Yes, excellent. Now you got what I was saying. Excellent, guys. The black box is still appearing? Because it's really annoying in the recording. Do you still see the black box? Okay, thank you. So inferior rectal, why not udendal? Why? Because it's not the direct branch. Sometimes they twist the question. Sometimes they say, which nerve, okay, or the nerve supply of the perianal area comes as a branch of which nerve? You got it? Yeah, it happens many times in arterial or nerve supply. So now the answer would be the udendal or pudendal, whatever you call it. Okay, which artery is most commonly injured during appendectomy? I think we are now solving 2024. The deep circumflex iliac artery. Yes, excellent. Okay, do you know which branch it comes from? Or what is the main artery, I mean? Excellent, yes. I need this. I need this. I need this level of awareness, especially in anatomy and pharmacology. By far, in my very humble opinion, those by far are the most tricky modules in your exam because they always appear with new questions. Yes, excellent. Okay. The outermost protective layer of Graafian follicle. Outermost, this is extra. Actually, I don't like this question. I hope I have a better format for this question. I'm really not sure. Did they mean the theca externa or they meant the outermost protective layer of the ova in the Graafian follicle? I have no idea. This one is really silly. Really, really silly. Yeah, sure. This is by far the outermost protective layer. Okay. But no, if I told you what is the protective layer of the ova in the Graafian follicle, choose one of those. Zona pellucida. Yes, excellent. This would be the zona pellucida. So I got you anyway. Okay, how it looks like, and you can make your mind in the exam. The corona radiata is not protective. It's not protective. The protective layer around the ova is the zona pellucida, and this is the layer that the sperm is going to penetrate. The sperm has no difficulties in penetrating the corona radiata, but he needs specific enzymes to disintegrate the zona pellucida, to lysis the zona pellucida. So zona pellucida is a protective layer around the ova. common iliac artery bifurcation level? Yes, excellent. It is L4 to L5, but mainly L4. Excellent answer. Excellent answer. Wallahi, look, guys, the majority is from L4. And until I saw this question, I was always answering it as the level of sacroiliac joint. And sacroiliac joint is somewhere between L4 and L5. But when I searched some in some papers and so, they mentioned that majority of people are from L4. So let's go for L4. Any bifurcation level is crucial in your exam. The bifurcation of aorta, the bifurcation of common iliacs, the bifurcation or when the iliac artery is going to give out its first branch, it's also important. The level where the ureters are going to enter the pelvis, okay, from lateral to medial. Okay, they are getting medially and entering the pelvis. This level is also important. The levels of the branches of the aorta, like every exam question. The dermatomal level of the umbilicus. Would you remember it? This is like every exam question also. They love it. What is the dermatomal level of the umbilicus? You know why they love it? Like really, wallah, you know why they love it? It makes sense. It makes sense. Do you know that when you have pain around the umbilicus, this could be in females, at least. This could be something coming from the appendix or from the ovaries. Exactly. So if a patient is having ovarian pain, this can be referred around the umbilicus, it can be referred inguinally, and it can refer to the back. So you need to know the level. Why? Because you now are aware where you are going to insert the level of regional anesthesia. If this woman is going to have PCA, if this woman is going for operation, okay, for an ovarian cyst or whatever. This is why it is related to your practice. Everything, by the way, is related to your practice, but very few examples of questions. Very, very few. Which episiotomy type is most commonly used in UK? And I have another question for you, because this one is really silly one. Yeah, the mediolateral. Can you give me the correct angle for the mediolateral episiotomy? I got different numbers. No, according to the Royal College, it is 60 degree. Why 60 degree? Because when you do it at 60 degree, you are going to achieve a 40 degree postpartum. If you do it by 40 degree, you are going to get like something between 30 degrees or maybe less postpartum after the involution of the tissues. When everything is going back to normal, you are going to find yourself, okay, the repair is very near to the midline. When you do it by 60, okay, after repair, you are going to see your suture here at this side. So take care, because this is very unique to the RCOG. I know that everyone everywhere is saying 40. Yes, it is 40, but this is what we want to have, not what we are going to cut at. Okay, so we are going to cut the episiotomy at 60 degrees. Excellent. Okay. During hysterectomy, which pedicles should be first ligated to control the bleeding? Let me tell you what, guys, when I saw this question, I thought that it was taken from part 2 exam, because this is a part 2 question. It still appears in part 2, but indirectly. Okay? So if I asked you which pedicle should be first ligated in hysterectomy, round ligament. And the round ligament, when you tie it and dissect it, you are by far decreasing the bleeding from the uterine artery and the ovarian anastomosis until you go on, okay, and dissect the infundibulopelvic ligament if you are going to remove the ovaries as well. If you are going to remove the ovary, you are going to ligate this one also. Okay, but this is the first one to be ligated. In vaginal hysterectomy, do you know which pedicle should be tied first? The uterosacral ligament. Uterosacral ligament, excellent. And it gave me another question now in my head. When we are dealing with uterosacral ligaments, whether you are ligating it or dissecting it or doing a fixation for the uterosacral ligament for prolapse, what nerve is liable to be injured? Genitofemoral is very above, it's not here. Actually, obturator is really deeper than this. The obturator is very back in the pelvis, and usually it is injured when we do lymphadenectomy for cancers and so. The udendal, internal udendal. This is also exam question, by the way. Okay. Do you know why? I have another one, by the way. It's more specific than udendal, but udendal is going to be injured because we are very near to Alcock's canal, and we are very near where the udendal is coming just beneath the sacrospinal ligament. Yeah, the sacrospinal ligament in sacrospinous fixation, for example. Yes, yes. I lost where we are. Yeah, we were talking about uterosacral ligament, right? Okay. I'm trying to remember another thing about uterosacral ligament. Yeah, in vaginal hysterectomy. It didn't happen to appear in your exam before, but anyway, the most common complication after any procedure that is dealt with uterosacral ligament is going to be buttock pain or perineal pain. This is one, and we said the dental injury, and I don't think they are going any deeper than this. Okay, so I brought you anyway the vaginal hysterectomy, Okay, you can see that the first one, where are we? Yeah, the uterosacral ligament. This is the first pedicle that's going to be ligated. Okay, androgen testosterone is converted to DHT by which enzyme? Where is my champions? Yes, 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 yes. Thank you, Dr. Medina. 5-alpha reductase. If I asked you, testosterone is converted to estrogen by which enzyme? Aromatase. Excellent. Okay, you know, guys, that we have medication to stop this enzyme. We have some medications to inhibit the 5-alpha reductase because we don't want the active form of DHT. Finasteride, yes, and this is, by the way, was a recall. It was a recall before. Yes, excellent. Because when you stop the formation of the active testosterone, you are going to treat some medical conditions like the benign prostatic hyperplasia or the male pattern baldness. And this specifically came as a recall before. They were asking about a specific medication, okay? The bromfenestride, I think, which is used by a specific male to treat male pattern baldness. How this enzyme work, or sorry, how this drug work, or what is the mechanism of action? It inhibits the 5-alpha reductase. Okay, so this is why we have a drug to stop this enzyme. So far, I'm so proud of you. Okay, when does meiosis starts in female embryonic life? Let me be honest. I didn't know this question and I had to look it up. Okay, it didn't come to my mind when exactly the meiosis is going to start in a female embryonic life. I know when she's going to have her reproductive organs and when she is going to form the very first ovary and primordial follicles, but exactly when I didn't know. So when I look it up, I found out that the meiosis, of course, it's going to start in the embryonic life, not like males, because we have meiosis 1 in utero, and then it's going to resume activity to meiosis 2. When? Who can tell me quickly? Our ovaries are freezed at meiosis 1. And then, excellent, they are going to resume to meiosis 2. No, not fertilization. Puberty. At fertilization, we are going to have another division because after puberty, the ova is going to enter a stage and it's not going to be completed. Okay, so meiosis is going to complete or resume by puberty. Going for meiosis 2, yes, you are right, by fertilization. Okay, maybe it's my mistake. I didn't clear it out. So yeah, exactly. So meiosis is not going to resume unless the patient is having puberty, and then meiosis 2 is going to be completed by fertilization. Yes, you are right. In males, The process of meiosis begins after hitting puberty. So the start of meiosis after hitting puberty. Okay, just in case they asked about. One of the exam questions, and it's a very silly question, very silly one. Which kind of cell or which cell in the human body is the biggest? Yeah, the ovum. والله يعني what shall I say? يلا الحمد لله. Okay. The maternal hormone responsible for glucose metabolism regulation in fetal life. Okay, I'm getting some reasonable answers. I'm really glad that someone said insulin, because you know what? Insulin is the main hormone responsible for glucose metabolism for any human being, fetal, infant, adult, old people, everyone. But if they mentioned maternal or placental hormone, this would be the human placental lactogen. Because the placenta does not secrete insulin enough to do this. Okay, insulin is secreted by the baby, not by the placenta. While human placental lactogen, yes, it is one of the most important hormones in pregnancy. HPL is responsible for many things. Many things. For growth, for glucose metabolism, for initiation of breastfeeding, maturation of the breast. Okay, lactogenesis to be specific. Okay, not mammogenesis, lactogenesis. So yeah, it plays a role in many things, even lipid metabolism. This question reminds me of, yeah, another hormone that is responsible for satiety or regulating the, I want to remember it exactly. I don't know if it's here or not. Yeah, you answered before I continue. I want to remember the whole question. Yeah, it's leptin, but leptin is not the only one that controls satiety. It's one of its functions. Leptin is really important also in regulation of sex hormones. Or let's say the regulation of sex hormones from the very beginning, from the hypothalamus. Leptin and kisspeptin, both of them are crucial for normal hypothalamic pituitary gonadal function. And leptin also is influenced by eating, how you eat, and how much carbs do you eat, and how often do you eat. Okay, so yeah, but this is not its only function. Just reminded me of the human placental lactogen here. One of the years, by the way, they brought them a curve like this. Once it was for the ovarian cycle hormones, estrogen, progesterone, LH, and FSH, and they asked them, what is this? Which one is this? And this is some hormones or placental hormones in pregnancy, some, not all of them, of course. So what is really unique about HPL or human placental lactogen is that it increases throughout pregnancy and plateau, and it's not going to decrease. It's going to plateau because it's responsible for lactogenesis, right? And it's going to drop down because after delivery, the placenta is no more. Okay, Allah yarhamha. So after delivery, we can see a drop in HPL when the prolactin is going to take over. The pituitary prolactin, not the placental prolactin. Okay? So human placental lactogen here is like placental prolactin, if you want to name it. So it keeps rising, 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 rising until after delivery it drops down. While estradiol and progesterone, both of them are going to drop even before delivery, especially progesterone, And I think if they want to ask you about a specific hormone, it's going to be this one or this one. HCG, by the way, came to part 2 many years ago. So yeah, why not? It's there, so they can use it. HCG is the kind of hormone that's going to fluctuate, but it's going to increase and peak, of course, at the first trimester, and then it's going to decline. Okay, what is going to take over the placenta in secreting HCG? The placenta still secreted. It's going to secrete it till birth. Okay, but I don't really need the HCG now for the same purpose. What would the purpose of HCG in the beginning of pregnancy? To support the corpus luteum, to secrete progesterone. Right? But when the placenta is now ready to secrete progesterone, the HCG is going to come down. Got it, guys? Which remind me of another exam question. What is the lifespan of corpus luteum? The normal lifespan of corpus luteum. This is also a recall. The normal lifespan is 14. Okay, in strategy, they answered it 12. Okay, and I know that it is controversial somehow, but remember in strategy, they answered 12. So if 12 is between the options, go for 12. Outside pregnancy. In pregnancy, it's going to stay alive for how many weeks? Okay, 10 to 12 weeks. Yes, 12 weeks by far, 12 weeks. The first trimester, you can remember it this way. The first trimester. Okay, and then the placenta is not going to secrete the same amount of HCG. HCG is going to increase a little bit before parturition or in the end of the second trimester, and then decline rapidly, because HCG is not only for this. It makes many things. HCG is important for the fetal growth. HCG is important for let's say, the balance of the other hormones. HCG is important for the maintenance of estrogen and progesterone throughout pregnancy, because if they are getting low, this patient is going to have miscarriage, and then what? Why she's having miscarriage, you know? The placental attachment are going to be really poor. Anyway, so I think this could come, or progesterone, because this is going to peak high in the third trimester and then drop just before labor. And I need this drop. I need this drop because I need to have labor. If the progesterone is still high, this patient is not going to get into labor, right? And she's not going to have easy placental separation. Okay, I'm just trying to make you remember, guys. Even I sound really, what shall I say? Not really scientific, actually. Oh, okay, gonadotropin releasing hormone is a monopeptide, decapeptide, polypeptide, steroid, amino acid derivative. So you remember this very well, alhamdulillah. You remember the common recalls very well. Okay. Deca means 10 amino acid. Would you remind me, please, about oxytocin? Nano or 9? Yes, nanopeptide. Nona? It's Nona, not nano. Nona. Yes, Nona. Nona peptide. Yes, or 9 amino acids. Okay. You know which type of hormones are steroids? Sex hormones. LH, FSH, uh, or, or estrogen and progesterone and testosterone. Yes, so estrogen, progesterone, testosterone are steroids. Excellent. While FSH and LH are mainly glycoproteins. Yes. I please go through them because those are very famous exam questions also. Another silly exam question, how many carbon atoms are there in estrogen? I really didn't know before this exam. Yes, 18. And please don't ask me why this is exam question in RCOG. I have no idea. Okay, I got you the others in case you want to have a look. Renin. Renin is enzyme or protein or steroid or lipid or what? Yes, it is enzyme, and they can ask you anything about the renin-angiotensin system, where it is secreted, how it works, what is the enzyme that's going to activate it, everything. Okay, in pregnancy, the typical acid-base status is I'm not happy. I'm not happy. Why you don't know this? In pregnancy, where we have a little bit of tachypnea and we are washing out the CO2. So if I wash out the CO2, this is alkalosis or acidosis? Alkalosis. Okay, I wash it out by vomiting or I wash it out by respiration. I wash it out by kidney or by respiration. Respiration, so it's respiratory alkalosis. This is physiological, okay? And this is going to stimulate the brain centers and receptors so that the patient is going to slow down the breathing and retain some CO2 inside so that we are going to back to normal again. Okay, so respiratory alkalosis is common, generally benign. Okay, everything is because of progesterone. I told you, wallahi, everything. Acidity, reflux, depression, the low gastric motility, the low intestinal motility, the low bladder contractility and UTI. Everything is because of that progesterone. Okay, which remind me of something, but let's go through this first. So when the patient is having respiratory alkalosis, the respiratory center in the brain is going to be stimulated, and they are going to lower the blood carbon dioxide and increase the pH. Okay? Anyway, look, guys, now I remember something about, um, actually, there are two. Yeah, okay. In nausea and vomiting in pregnancy, what would be the expected acid-base imbalance in someone with severe NVP? Metabolic alkalosis. Yes, okay. Mainly you are going to find which minerals low? Low sodium, low potassium, low chloride. Everything is low. Mainly potassium. Okay, another exam question. Uh, of course, you know that lung function in pregnancy is a must. Okay, and which one is sustained, which one is lower than normal, which one is higher than normal? Those are musts. The spectrometry is also a very common exam question. I should write down. I forgot the other one. Okay, progesterone. It was the reason why we are having everything that. Oh, if I remember it. Yes, I remembered. Okay. POPs or any progesterone-based contraception. What would be the most common side effect? No. POPs in general. Okay, let's talk about POPs. But if I talk in general like this, it's not erratic bleeding. They are really, really related to psychological symptoms. Low mood, weight gain, and depression. Yes, if I talk in general, it would be weight gain and mood disturbances. Okay. You know CRISPR-Cas? This question appeared for the first time, I think 3 or 4 years ago. So what do you think? What CRISPR-Cas do? This is an enzyme, by the way. Have you ever heard about CRISPR-Cas? CRISPR-Cas is like a scissor, okay, that we are going to use to cut a piece of the DNA sequence and alter it by whatever we want. It's an enzyme, excellent. Cas9 is an enzyme, okay, and CRISPR itself is the DNA sequence that you are going to use later on. So CRISPR is the DNA sequence found mainly, I think it was a bacteria, okay, in which they had their first this technology on. Cas9 is the enzyme or the protein that is like a scissor, cutting the DNA at a specific location. Then they discovered that this system was, let's say, adapted by the bacteria as a defense mechanism against viruses. So after what I have said, choose the best option in front of you. Actually, it is not enzyme. Okay, take care because the order is important. Okay, so CRISPR is DNA. Cas9 is what? Enzyme. So D is not correct. Now, would we call Cas9 a transcription? Would we call it like this, a transcription? They call it what? Transcription factor? Or just an enzyme? You know, guys, what is a transcription enzyme, or what are the transcription enzymes in our replication of DNA? Do you remember those very basic knowledge? Okay, Cas9 is not a transcription enzyme or factor. Okay, it's not a transcription enzyme. And I know that this has been answered as that Cas is a transcription factor. No, it's not. CRISPR is DNA. Okay, a part of the DNA. It's a DNA sequence. Cas9 is enzyme. It's not a transcription factor. This enzyme is going to lead the transcription factors or guide the transcription factors, how to work. But it's not a transcription factor. So I think the correct enzyme would be DNA enzyme interaction. Okay, do you agree? I don't know if you agree or not. Anyway. So yeah, this DNA enzyme interaction, this is what I think. Blood supply of lower part of round ligament. I'm not sure if it was really mentioned as a lower part or blood supply of round ligament because it's only one. I don't know. Maybe they said so because, yeah, the upper part is going to have blood supply from different areas. This is called artery to the round ligament or Samson's artery. Samson's artery here was one of the choices or not? So it was inferior epigastric or it was Samson's? Because yeah, you are right, Dr. Faisal. The Samson artery comes from the inferior epigastric. So if anyone was in the last exam, this is a January 2025 question. If anyone can help us, okay. Anyway, so what I know that the blood supply of round ligament is mostly anastomosis of uterine and ovarian artery, but it has a definite branch to itself. It's called artery to round ligament or Samson's artery. This artery, as Dr. Faisal said, I could add it here. It's a branch. If we talk about inferior epigastric, we are going to spend like half an hour of inferior epigastric. Guys, inferior epigastric artery, origin, how it's used to identify things in laparoscopy, its risk of injury during laparoscopy, how it runs, okay, in a picture. I want to discuss some pictures with you. I have some pictures here. They are great. Okay, I have many pictures here that appeared in the exam before. One of them, for example, is this. This appeared with different labeling. This appeared once for superficial epigastric artery, and it appeared as inferior epigastric artery, and also it appeared as ascending branch of deep circumflex artery. I'm telling you, 3 different exams with the same picture, and each is a different labeling. So be aware, please, of the blood supply of the abdominal wall. This is crucial, okay? Surgically, it is crucial. So let's hope we are going to discuss all of those. This one, I don't remember it appeared before, okay? I'm not really sure, but only one candidate said that the pointer was not up here, it was down. So just in case, I brought it to you. That this one here that runs parallel to the inguinal ligament, and it's a superficial one, of course, is a superficial circumflex iliac artery. This is a superficial circumflex. The one that ascends up, it comes from the deep circumflex iliac. And this one that ascends up is called ascending branch of deep circumflex. Deep circumflex is not apparent here, it's deep. Okay? In last January 2025, they told me this one was the labeled one. And if you have a look, this one is a superficial one because they dissected the other part. So this is deep and this is superficial. Even you can see the fascia over the rectus abdominis muscle. So this is superficial epigastric. If they remove the fascia and now we are dealing with an artery that is just beneath the muscle, okay? So this is the inferior epigastric. Okay, inferior epigastric artery have many questions. Many. So everything you need to know about inferior epigastric, please do. Especially laparoscopy. Who can tell me inferior epigastric is a branch of what? External iliac, excellent. Yes, external iliac. Okay, inferior epigastric artery is located on anterior surface or posterior surface or lateral sides of rectus abdominis. See, it's tricky. Actually, it is located on the lateral side first, and then it's going to puncture the rectus sheath from behind and then travel upward within the sheath. Look at the picture. Look at the picture. It is not on the muscle. It is behind the muscle. Okay, sorry, behind the rectus sheath, on the muscle. I got conflicted. Okay, let me use the picture. Let me use it. See, you know when we flip the rectus to see the inferior? Okay, whoever said that we see it on the posterior surface, you are right. Okay, so it starts lateral to the rectus abdominis muscle on the lateral surface, and then it's going to puncture the sheath. Okay, and when it punctures the sheath, it's going to run upwards within the sheath. Within the sheath. Okay, so yeah, when it runs within the sheath, it's going to be between the fascia and the posterior surface of the rectus abdominis. Okay? So yeah, it's going to run between transversalis fascia and the rectus abdominis muscle. So it's going to run here. So this is why when we flip the rectus abdominis during CS, we try to search for any bleeder and cauterize it or suture it, whatever you prefer. Okay, so remember it this way. If they asked about it, it should be running on the lateral surface first, then it's going to puncture the sheath, okay, and run behind the rectus muscle. I'm sorry, I think I'm getting tired. Okay, let's back to those questions. We can have a meeting tomorrow, by the way, if you want. Everything for you before the exam, I'm okay with it. Where we are. And I'm really trying my best to remember different kind of questions, so pardon me if we are taking some time. I can skip some. Yes, definitely. Definitely. At least you would remember us in your prayers when you enter the exam. Hopefully, inshallah, you are going to do that just fine. Where were we? Okay, here. A very silly one. The breast milk contains which of the following carbohydrates? It's a milk. After all, it's a milk, so lactose. Okay, which prostaglandin increased during the menstrual cycle? Where are my champions who revised pathology with me? Where are they? F2 alpha. F2 alpha. Okay, and by the way, this could be the prostaglandin that also increased during parturition, and this is why the contractions are very painful. Okay, excellent. So I got you also this one. If they asked you about which inflammatory mediator is reduced, this would be prostacyclin. Prostacyclin is myometrial relaxant. So of course, when the levels are reduced during menses, we are going also to have painful menses. Okay, immunoglobulin that increased in the pregnant cervix at term. This one is repeated. Let me ask you guys, which immunoglobulin is usually increased in the mucosal surfaces? IgA, excellent. But let me tell you that this is not the abundant one at term. Yes, IgA, of course, is going to be there because it's a mucosal surface anyway. But the one that is predominant by term is the IgG. And it makes sense, actually. Okay? Because the IgG play a local immune defense. This is why you remember that if a woman got chickenpox just before labor or in the third trimester, we are going to try our best to postpone delivery at least a week. Why do you think? Because I need the IgG to develop. Second thing is, there are two types of IgA actually. Okay? The secretory form of IgA, which is the most abundant one, it's there. Yeah, and okay, but it's more predominantly in secretions, not on the surface. So if they asked you about what would be the most abundant immunoglobulin in milk, for example, this was an old recall. In sweat, for example, this is also IgA. So I think I would go for IgG. If you approve it, it's okay. If you don't, you can go answer it whatever you want. The most common cause of female urethral caruncle. This is a recent talk article. Do you have any idea? Yes, it is hypoestrogenism, and this is not the only thing that can happen because of hypoestrogenism. Many things in menopause are because of hypoestrogenism. All the menopausal symptoms are because of hypoestrogenism. When I tell you if a woman is having vaginal dryness, dyspareunia, and urine urgency, she's menopausal, what would be the main cause of those symptoms? Again, hypoestrogenism. What is the reason why a menopausal lady is having recurrent vaginal infection? Hypoestrogenism. Why a patient in menopause is having low libido or low sexual drive? Hypoestrogenism. Okay, if a woman in menopause is having hirsutism, what would be the first thing that you want to exclude? Do you know? Which ovarian pathology? I'm trying to make it easier. Hirsutism in menopause is not a common feature or symptom. So if a woman is having hirsutism, or even hyperandrogenism or virilization. Androgenic secreting tumor. Okay, excellent. But there is something more common than a tumor. Have you ever heard of ovarian hypertrichosis? Ovarian hypertrichosis. Yeah, what happened in ovarian hypertrichosis? Most of the ovarian cells are differentiated into theca cells, not granulosa cells. In this case, I mean, okay, when it is abundant process or a progressive process, and most of the ovarian cells now are differentiated into luteinized theca cells, they are going to produce excess androgens, of course. And guess what? We don't have the granulosa cells to convert them to estrogen. So they are going to be testosterone, and the testosterone is going to give us the picture of hyperandrogenism. Who remember the two-cell theory? Granulosa cell and theca lutein cell. Theca lutein or theca cells are going to be stimulated by the LH, and it's going to secrete androgens or testosterone. They are going to move to the next or the nearby cells, which they are the granulosa cells. Granulosa cells contain the specific enzyme that can convert testosterone into estrogen, aromatase. So this is why granulosa cells secrete estrogen, and this is why theca lutein cells secrete testosterone. This one cannot convert testosterone to estrogen. And by the way, this is a recall. Why granulosa cells are able to convert or secrete estrogen while theca cells cannot? Because aromatase is present in granulosa cells while it's not present in theca cells. This is an old recall, and it's a basic one. Can you tell me, please, which type of ovarian cancers are estrogen secreting one? Granulosa cell tumor. Yes. Granulosa cell tumor now. If I want to give it a classification, shall I call it sex cord tumor? Or shall I call it non-epithelial or epithelial? Or mixed? Or what? Which type of ovarian tumor? It's considered non-epithelial ovarian tumor, yes. And it's considered sex cord stromal tumor, yes. Okay, all of this can come in the exam, definitely. Okay, granulosa cell tumor, guys, is coming from specialized cell. It has a name. granulosa cells. So if I'm dealing with epithelial ovarian tumor, this is something in the, let's say, the coverage, or what shall I name it? The outer wall of the ovary. This is the epithelial ovarian tumors. But when the tumor comes from a specialized cell inside the ovary, we are going to name it by its name. So if it comes from the sex cord, we are going to call it sex cord. If it comes from the stroma, we are going to call it stromal tumor. Okay? If it comes from, let's say, from the ova itself, and so on. Okay? Yeah. So yeah, granulosa cells secrete estrogen. It's non-epithelial, sex cord, stromal cancer. Okay. If I remember something, I would tell you. And of course, if it happened in a young age, it can cause pseudo puberty or precocious puberty. You know, some anatomy questions are like a puzzle or a charade. So in this one, not only, this is not the only one like this. Which nerve descend through the fibers of the psoas major and emerge from its medial border? Obturator. Okay, someone please tell me which nerve descend through the fibers of psoas major or run at its lateral border. Run in the lateral border. The genitofemoral is not running on the lateral border. I think those were the options. Femoral. Okay, I think we need to revise this one. The lateral femoral cutaneous runs lateral to the psoas. It does not run on its lateral surface or lateral border. Let me get you the picture. Maybe they would bring it in the exam. Psoas muscle. The psoas muscle relation to all nerves are, they brought everything about this muscle. Everything. Wallah, I'm not kidding. Its nerve supply appeared in the exam. The borders and how it's related to different nerve roots. Okay? Sometimes they ask you about the lateral cutaneous nerve because it is the one nearest to the anterior superior iliac spine. Are you aware of that recall? I'm sure the one of you that are really concerned about the recall, they know this one. Lateral cutaneous nerve is the nearest one to anterior superior iliac spine. Femoral nerve runs on its lateral surface. Obturator comes out from its medial surface. Genitofemoral pierce it and run on the anterior surface. Iliohypogastric and ilioinguinal are very up high and they are not related to its lateral surface directly. Okay, the one that really run on its lateral surface is the femoral. You know that this picture here came with many other forms. Obturator, guys, as you can see, is the nerve that is going very posterior in the pelvis. And this is why the obturator is not really going to be injured unless you are dealing with pelvic extension or pelvic lymphadenectomy. It's very deep, very behind. While femoral nerve here, during its descent on the lateral border of psoas, and of course it's going to its route until the knee and give branches afterwards. It can be injured because of, number one, the usage of heavy lateral retractors. So if I'm using a retractor here during my work and I'm using a heavy one, the one weighted one, okay? Not the one we hold it with our hands. There are some retractors that you are going to find a huge ball at their end because it's going to take the retractor down, okay? And there are other retractors that we are self-retracting them by our hands. So if you are, let's say, having, assisting in hysterectomy, let's say, so you are going to be the one who handle the retractor. If you handle it very strongly, okay, you are compressing on the femoral nerve here. And this is one of the mechanisms how we can injure the femoral nerve. If the femoral nerve is injured, the patient is not going to be able to choose from what I'm going to say. She's not going to be able to climb upstairs or get down stairs or ride a horse or kick a ball or stand uprightly. Excellent. She's not going to be able to climb a stair. Why? Because femoral nerve is the main nerve for hip adductors. So she's not going to be able to raise her hip up and climb the stairs. While obturator, if it's injured, am I going to have a big problem with muscles or mainly pain? Mainly pain, okay? Unless the patient is riding a horse or trying to keep a ball between her legs. She's not going to be able to do this. Why? Because the adductors of the thigh, not the hip. The adductors of the thigh, here and here, are weak. And of course, she's going to have pain and a paresthesia in the medial aspect of her thighs. Medial and posterior aspects of her thighs. Who can tell me which nerve is responsible for the sensation of the lateral part of the thigh? Lateral cutaneous nerve of the thigh. Duh. Right? Okay, which nerve is responsible for the anterior surface sensation? Some lateral, some medial, but mainly anterior. Femoral nerve. Excellent. All of those are exam questions, and all of them appeared in the exam before. Okay? Another exam question. If the patient is having pain and paresthesia on the pubic area here, over the pubic area here, sharp pain, and then paresthesia over the pubic area. Which nerve mainly is injured? If you want to choose from those. Ilioinguinal, excellent, excellent. And if I told you that it's not only on the pubic area, it's also there in the lower part of her abdomen. The iliohypogastric is also injured. Yes. Do you know that ilioinguinal and iliohypogastric, when they come down, they are superficial mainly, and they are injured during something in cesarean section, a step in the cesarean section, that when it's done incorrectly, you are going to injure the ilioinguinal and iliohypogastric. This is mainly when you do a penisteel incision. Excellent, Dr. Yekok. I'm so proud of you. MashaAllah. When you are doing a penisteel incision and you extended the excision more than it's the requirement. We should do a 2 to centimeter incision, just like this. When you extend the incision like this, you are going to hit the ilioinguinal plus or minus iliohypogastric. So again, this could be exam question in a scenario, right? Okay. If they asked you which nerve has been injured during vaginal delivery that rendered the patient with a pain around her vaginal orifice and her labias. This is injury to which nerve? I think I have a picture here. Udendal. Exactly. Yes. Pudendal or udendal. I don't know which one you favor. Okay, but it's udendal. The P is silent. The American school udendal. Where is it? Where is it? Well, it was here. Ah, here it is. Yes. I got you this picture for this reason. Because the sensory innervation, guys, for any area here is important. So yes, when it is about the labias and around the vagina and the inner, around the anal opening, this is udendal. The inguinal, mainly, okay, in the pubic area, above. If we got above this level and we got the lower abdominal part, iliohypogastric. If we are talking about a part of, not the gluteal, no, the gluteus is very posterior. The inner part of the thigh, here, and it's also involving a part of the pubis. This is posterior femoral cutaneous nerve. The genitofemoral nerve is important also, but it supplies which area? From the name, the genitalias. The genitalias mainly. Okay, so it's really apparent in males. Let's say it's really apparent in males because it's going to supply their scrotum and part of the skin of their pubis. No, we don't. We are not going to hurt. Which one in the inguinal canal? Which one? Genital branch. Yes, yes, genital branch. Yes, and this is why it's not really injured in our practice. Right? So this is why. Mainly this is why. But yeah, you are right. It does supply the genitalia. It does supply the scrotum. So in females, the equal of the scrotum is labia majora, right? And some part of the pubis, yes, and in females, some part of the skin of the pubis. But it's not going to be the scenario of someone who is having vaginal delivery and now she's having pain in her labia and around the vagina and around the anal opening. Do you agree? If we are in general surgeons now, I would tell you that during your operation for inguinal hernia, the patient after the operation is feeling sharp pain or paresthesia in the genitalia. So yes, of course, now you have injured the genital branch of the genitofemoral nerve, right? Which nerve also runs inside the inguinal canal? The ilioinguinal, yes. The ilioinguinal also. Excellent. Okay, so we have reached question number. Okay, we can take also those two questions. Okay, this is the caruncle. I don't know why it's here. This is how the caruncle appear. In case it appear in the exam, this is mainly a benign condition. Okay, we are only going to suspect that something is really malignant when it's fungating or easily bleeding, or it's getting bigger and bigger by time. Okay, but otherwise it is because of estrogen deficiency, and we treat it by estrogen, local estrogen. Whether it was gel or cream, we treat it by local estrogen. Okay, so let's take this one and this one and continue tomorrow. During laparoscopy, assisted vaginal hysterectomy. If this was for part 2, it would be a very different question. Surgeon accidentally damaged the ovarian artery. Which is correct about left ovarian artery? This is absurd. I would tell you another thing. This kind of operation, the laparoscopy assisted vaginal hysterectomy, is by far the most common one to cause bladder injury. Okay, more than vaginal hysterectomy alone and more than laparoscopy hysterectomy alone. This one is very prone to cause bladder injury. Okay, which one of the following nerve roots mediates the anal reflex? This would be S3 and S4. Okay, and you remember, of course, that the inferior rectal nerve and middle rectal and superior rectal are of different origins, right? So let's revise their origin. I'm sorry, I'm so mean. Who remember? Who can remember the inferior rectals come from? Okay, you got it from up. Okay. So the superior rectal is from the inferior mesenteric artery, inferior rectal artery from internal udendal. Okay, the middle is also from excellent internal iliac. Yes, not from the udendal. It comes from the internal iliac. Excellent, guys. MashaAllah. Okay, and for the nerves, the inferior rectal comes from udendal nerve. Sometimes it takes branches from the sacral plexus. This is also very important exam question. Superior rectal nerve. A branch of what? Just like the artery. Inferior mesenteric plexus. See, it's very, very easy to remember. Okay. Okay, guys, thank you so much, Wallahi, for attending. And I hope, inshallah, that you are going to revise. I'm going to send you the file that we have revised together today. Hopefully, we can have a meeting like this tomorrow, if you don't mind. Okay, if you feel that this was beneficial for you, we can go on tomorrow. If you don't feel that it was very beneficial, I'm anyway going to have a meeting with my candidates, the course candidates. Tomorrow is Monday, so I think the same timing. But I'm going to ask my candidates first. If they prefer a late one by evening, I'm going to write it on the group. I'm going to send it to the Telegram groups also. We reach it here, so I can go like this and send you those. So whoever wants to have a session tomorrow, please write to me in the group. Okay, and I'm going to have a voting over the timing. I really wish if I can answer all recalls with you, but this is like impossible. So again, guys, it's not about recalls only, especially if we are dealing with clinical scenarios. It's not, the recalls are not going to save you. So yeah, of course, you can go through recalls and everything, but also I'm going to send you the important guideline that you should be aware of: epidemiology, incidence, main treatment lines, main investigation, if any. Okay, and some of them are going to have information here or there regarding microbiology, like incubation period, like which family this bacteria or this virus is. Okay, like for example, in PCO, what kind of interleukin. This is a recall that it's a recent one. Which interleukin is the most commonly found in PCO patients? 6 or 8? You know, we have also what's called treasure box in the Telegram group. It's a hashtag. You can go through it. You are going to find many useful things. You would be, no, I lost it. Okay, I'm going to send it to you, don't worry. So is it interleukin 6 or 8? Last call. You know that we don't bring the answers from Google or something like this. We don't do this. There are resources for the answers for the questions, and it should be MRCOG resources. Both of them are there. Actually, both of them are there. But according to our dear college, and according to a top article in which it was mentioned, no one is telling me. So I'm having different answers. So let me send it to you to the group. Okay. Thank you guys so much. See you tomorrow. I'm waiting for which time is okay for you. I'm going to send the poll right now. Thank you so much. Assalamu alaikum.